All right. Hi, everybody. I'm going to make sure that you all have access to the chat here real quick. Let's see. And here we go. I just want to make sure you all can chat with everybody. Perfect. Okay, great. Awesome. Well, to take things off. My name is Brooke McGivern. I'm a speech pathologist here with Tim's Medical, and I'm super excited to be accompanied by Megan and Shannon as we dive into our presentation, Leveraging Quantitative Analysis for MBS and FEES. Just a couple of quick housekeeping items before we get started. This session is eligible for 0.15 ASHA CEUs or 1.5 PDHs. In order to obtain ASHA CEUs, we ask that you stay for the entire duration of the session and that you complete a brief survey within 7 days of course completion. We will put that link to the survey in the chat, and then it will also be sent out to you via email. And then if you'd like a certificate of completion for attending this webinar tonight, we ask that you send us an email at tims-univ@tims.com with your first and last name, and then just give us the course title so we know that you're wanting a certificate for this course. And we want to mention that this webinar does come with accompanying resources, including web pages detailing each of the analysis methods discussed tonight. Additionally, we will provide a replay of this session on the TIMS website within 48 hours. And we want to note this webinar covers a ton of complex topics. So in order to maximize learning, we will provide all the information you need to review the given resources and to obtain ASHA CEUs and certificates in the chat. And then we will send that information out again via email twice from Zoom. So we hope that those resources help you relax and enjoy this presentation. There's no need to stress about taking notes or screenshots unless you just want to, because we will ensure that all of the information is accessible after the webinar concludes. So with that, I'm going to go ahead and share my screen here so we can get into our content. Let's see. And then if you do have questions during the session, feel free to pop them in the chat or the Q&A as we go. Okay, let's see here. And then perfect. All right, so to kick things off, we just want to start with a brief introduction about Tim's Medical. So our team here at TIMS are passionate about improving patient outcomes, which we believe that TIMS MVP helps to facilitate. And our role today as presenters is really to empower and improve patient outcomes. And we hope that this presentation helps facilitate discussion and collaboration. Our agenda for the webinar tonight will include an overview of research and best practices for MBS and FEES analysis tools, as well as quantitative measures, application of analysis tools, and more information about immediate application of the discussed methods. Finally, we will conclude the session with more information about exciting initiatives that we hope will really help improve access to educational opportunities, advance interdisciplinary collaboration, and improve patient outcomes. I do want to note that this presentation will discuss the use of TIMS MVP for both MBS and FEES, but that said, everything that we discussed tonight is beneficial for those with or without TIMS for MBS or FEES. Here are our learning outcomes for the session. And like I said at the beginning, my name is Brooke McGivern. I'm a practicing speech language pathologist in acute care, inpatient and outpatient rehabilitation. And I am a member of our marketing and clinical education and training team here at TIMS Medical. And with that, I'll hand it over to Shannon to introduce herself.
Hi, everybody. My name's Shannon Marks. I'm also a speech pathologist, and I'm one of the training managers here at TIMS Medical, and I help support our clinical education. And I'll pass it over to Megan.
Hi, everyone. My name is Megan Voss, and I am also a speech pathologist here at TIMS Medical. I support the training of our customers and also the clinical education team.
Awesome. And just to make things less distracting for the presentation, we're all going to turn off our videos, but we'll turn them back on at the end of the presentation as we go through Q&A and then take you through a tour of the software if you would like us to. Go ahead and turn off my video. All right, so diving into our presentation, let's begin by discussing quantitative measures. Quantitative measures have been shown to improve diagnostic accuracy when compared to qualitative measures alone. Further, we know that standardized approaches support reproducibility, transparency, reliability, and a consistent patient experience while promoting clear expectations, best practice adoption, and improved patient outcomes. The tools and scorecards within TIMS MVP have been developed and refined to support these goals. We want you to know that we are always open to feedback and collaborative opportunities, including suggestions for software development, updates, and changes. This presentation will provide an overview of the tools available in TIMS MVP 6.1, as well as illustrative examples of their use. Implementation of the tools should be tailored to the needs, expertise, and clinical context of each individual team. As mentioned, the goal of tonight's presentation is to provide an overview of selected analysis and measurement tools, which are all available and applicable within TIMS MVP, but it is not intended to represent all possible swallowing measures. We do want to note that TIMS MVP does not prescribe or prioritize specific metrics. Rather, it offers configurable tools to support diverse measurement approaches. As users, we are responsible for selecting, implementing, and validating measures in accordance with research study design and clinical objectives. Measurement selection and interpretation should always be driven by theoretical framework, research and clinical questions, as well as individual expertise. As we begin this webinar, we want to provide an overview of several analysis methods that are commonly used in clinical practice, graduate education, and research. The methods highlighted this evening were selected because they provide standardized approaches for evaluating swallowing anatomy and physiology, safety and efficiency, and function across the swallowing continuum. Together, they illustrate how analysis tools can complement clinical observation by improving objectivity, consistency, and transparency in swallowing assessments. While these represent many widely used approaches, they are not intended to be an exhaustive review of all analysis methods available. Many of the analysis methods we will discuss incorporate quantitative measures, standardized rating scales, or structured frameworks that reduce subjectivity and improve reproducibility. Many of these tools are currently integrated into the TIMS MVP software, while others are in active development. Importantly, each of these methods can be implemented today using the tools within TIMS MVP. TIMS MVP was developed to support standardized and quantitative swallowing analysis by providing clinicians with tools that streamline measurement, improve our workflow, facilitate collaboration, and enhance clinical decision-making. By making objective analysis more accessible in everyday practice, we hope that these tools will help clinicians generate more consistent, reproducible, and data-driven assessments while supporting high-quality patient care. As evidence and best practices continue to evolve, we remain committed to expanding these capabilities in future software releases. With that foundation in place, let's explore several of these analysis methods now. First, we'll begin by discussing the Modified Barium Swallow Impairment Profile, or MBS-IMP. MBS-IMP is a standardized method for teaching, assessing, and reporting physiological swallowing impairments based on observations from the MBS study. It covers the assessment of 17 components of the adult swallowing mechanism and includes a scoring system to objectively profile these impairments. The MBS-IMP enables clinicians to communicate MBS results in a consistent, specific, accurate, and evidence-based manner. A few pretty incredible facts about MBS-IMP. There are 12 boluses administered during the MBS study as part of the MBS-IMP validated protocol, and 17 physiologic components of the swallowing mechanism are evaluated as part of the standardized assessment. 200 universities are currently using the MBS-IMP standardized training within their dysphagia class curriculum. 7,900 SLPs to date have completed the MBS-IMP standardized training and testing, and 145,000 MBS-IMP swallow studies have been added to the Global Swallow Data Registry, which have contributed much needed data to further the study of dysphagia. I will note that you can actually upload your MBS-IMP scores to that global data registry that I just mentioned through TIMS very quickly, and Megan will talk about that later in this presentation. Next, we are going to discuss the dynamic imaging grid of swallowing toxicity, or DIGEST, which is a validated system designed to evaluate the severity of pharyngeal swallowing impairment. Originally developed for video fluoroscopy in patients with cancer, DIGEST has since been validated for use in other populations, including those with neurological conditions causing dysphagia and in the acute care setting. DIGEST has also been adapted for use in FEES via DIGEST FEES. The analysis of swallowing physiology, events, kinematics, and timing for use in clinical practice, or ASPECT-C method, was developed as a streamlined version of the full ASPECT method to provide a practical, time-efficient approach for routine clinical use during video fluoroscopy. Its primary goal is to help clinicians identify the physiologic mechanisms underlying impaired swallowing safety and efficiency, where swallowing safety is defined as the ability to protect the airway, and swallowing efficiency as the ability to clear material through the pharynx. The method focuses on 8 key swallowing parameters selected from analysis of multiple clinical data sets because they most consistently explain penetration, aspiration, and post-swallow residue across a wide range of dysphagia populations. These parameters can be compared with published normative reference values from healthy adults to support interpretation of swallowing impairment. Next, we will discuss the Robust Esophageal Screening Test, or REST, which is a validated and standardized esophageal screening protocol that is beneficial in specifying and expediting next steps for multidisciplinary teams. The REST demonstrates high sensitivity and specificity for detecting esophageal abnormalities. Additionally, a quality improvement project revealed the feasibility of implementation of the REST. Next, we will discuss the visual analysis of swallowing efficiency and safety, or VASES, which is a standardized method for evaluating pharyngeal residue, penetration, and aspiration during FEES. The approach defines clear anatomic and temporal boundaries for rating swallowing outcomes, promoting consistent interpretation of examination findings. By standardizing FEES analysis, VASES aims to improve the transparency, sensitivity, reliability, and generalizability of swallowing assessments for both clinical practice and for research. If you would like to learn more about the analysis methods that I just discussed, we would encourage that you check out our complimentary on-demand webinars, which include presentations regarding each of the tools that we just reviewed. You can also access our free on-demand webinars using the QR code above, and this is another one of those links that will be sent out to you via email after this course concludes. We'd also encourage you to visit the sites of each of the method and/or labs that we just reviewed, because each of those teams or researchers have further training and educational offerings. So with that, I'll go ahead and hand the floor over to Megan.
Thank you, Brooke. To keep everyone oriented to where we are in the presentation, the slides have been organized into section objectives. So first, let's dive into the TIMS assessment tools. We'll begin with an overview before exploring the performance tools, playback tools, toolbar orientation, and a few important considerations to keep in mind when using these features. To begin exploring solutions that TIMS offers, let's first discuss study performance capabilities. As we know from publications since 2009, the use of lower pulse rates results in diagnostic inaccuracy when performing a modified barium swallow study. Experts recommend using 30 pulses per second or continuous fluoro. TIMS allows users to capture synchronized audio and video at 30 frames per second or continuous fluoroscopy. As you are performing the study, preset or customized label sets can also be easily applied to individual trials, streamlining the review process. This video demonstrates the use of label sets. As shown, users can implement preset label sets such as MBSS, or they can create customized label sets. As you're administering trials in real time or reviewing the study, you can select the corresponding label using the toolbar just above the clip. You can also input free text using your keyboard. The TIMS review workflow is one of the key advantages to having the TIMS MVP software. The goal with TIMS review is to improve patient throughput and increase clinician ability to review studies and complete associated reporting. As shown in this diagram, TIMS MVP and TIMS review allows teams to record the study, send the data to their preferred TIMS review workstation, freeing up the Flora room for more patients, and finally send the completed study and/or report to your PACS or VNA. And TIMS additionally allows teams to integrate the information from the MBSS into the EMR. Now let's dive into measurement capabilities within TIMS. The software allows for a variety of measurement types, including timing, length, area, and ratios. The timer tool supports analysis of temporal events. The line measurement tool allows users to assess linear distances of a specified structure or region. And the freehand tool, magic wand, and magic brush enable the outlining of a defined region. The outlined regions generate area measurements expressed in pixels. Additionally, the area-based tools can be used to calculate ratios. A scalar can be set, which allows subsequent measurements to then be expressed as a percentage or ratio of the original scalar. Now let's discuss the playback options in the TIMS MVP software. So as we all know, reviewing frame by frame is a key aspect of MBSS analysis. This video demonstrates how TIMS MVP can be used to review a series video frame by frame. When reviewing a study, you have the option to adjust your playback speed, loop a particular series video, and play all series videos using the tools on the left-hand side of the timeline as shown here. So just in that bottom left-hand corner, you can see you're able to adjust that playback speed all the way up to ×2 the original speed, or you can also slow it down all the way down to 1/4 of the original speed. And then you, of course, have those options for how you would like your study images to play back, if you'd like to see those on a loop or play through the entire study as a whole. Now we will discuss the toolbar orientation. So here you can see a snapshot of the toolbar within the software. To open the toolbar, simply click on the double arrow on the bottom right-hand corner titled Toggle Advanced Toggle Advanced Controls. Your toolbar will then open as shown here. To open the annotation part of the toolbar, click on the paint palette icon, and that will have toggle annotation mode activated. We've listed key tools within the toolbar, which will be beneficial for measurements and recording pertinent information. This video demonstrates a review of the tools within the Toggle Advanced Controls. As you can see, there are many tools available, including the pointer for education, the freehand tool, line tool, circle, magic wand, magic brush. You can also change the color you're using and can increase or decrease the width of the outline. The tools just described can be used to delineate important information such as anatomical findings we wish to point out, area measurements, and percentages. And many of these tools will be reviewed in more depth later on as we get into the different measurements. This slide is taken from the training guide. This infographic demonstrates a quick overview of the tools we just discussed. If you want to locate the training guide, you can click Help in the top left-hand corner of the software and click on Training Guide, and that will give you a PDF version of our training guide there. So then a few additional considerations. The freehand tool initially provides the length of the line. Once snap to close is complete, area measurement is provided. It's important to ensure that snap to close has happened so that residue data is not inflated. Difference in image resolution may impact which tools you can use for measurements. So for example, one of our colleagues has access to 2 different fluoroscopy units. While he's easily able to use the magic wand and magic brush for videos obtained with one of the units, with the other unit, he's often required to utilize the freehand tool. I do want to note that our engineering team became aware of this issue after the TIMS MVP 5.0 release and has since improved both the magic wand and magic brush in order to increase the ease of their use. If you've recently upgraded your TIMS MVP software, be sure to try these new features. Great. And with that, I'm going to pass it on over to Shannon.
Thanks, Megan. So next we're going to dive into temporal measures. On this slide, we have highlighted 3 important components of temporal measures and where to view them within TIMS. On the left side of the screen, we can view the recording rate, which in this case is 30 frames per second. On the right side of the screen, we can view the frame number, which changes as we review along the timeline, as well as our timer tool. When we click on the frame number, a pop-up appears with additional data we can review, including the image number, study image number, image time, recorded time, and elapsed time. A few important points that we wanted to bring up about temporal measures is that delta represents a time difference between events, but it is reported in seconds. The delta is that triangle to the right of the time. To convert data captured in seconds in TIMS and milliseconds, we will multiply by 1,000. We also wanted to mention for your timing data that 1 frame equals 33 milliseconds if you are capturing at 30 frames per second, and 1 frame equals 40 milliseconds if you are capturing at 25 frames per second. Next up, we're going to talk about a couple examples of temporal measures. So 3 examples include upper esophageal sphincter opening duration, laryngeal vestibule closure duration, and time to most complete laryngeal vestibule closure. Now we'll take a look at a few of these in more detail. Esophageal sphincter opening duration provides data regarding the amount of time that the UES remains open during bolus passage from the pharynx to the esophagus. To complete this measure, we will advance frame by frame until the first frame of UES opening, then turn on the timer, then move forward frame by frame until the first frame of UES closure. Data will then be obtained in seconds, and to convert to milliseconds, we will simply multiply by 1,000. Laryngeal vestibule closure duration is a measure of how long the laryngeal vestibule maintains complete closure. To complete this measurement, we will calculate the time between the first frame of laryngeal vestibule closure and the first frame of laryngeal vestibule reopening, and this is typically measured in milliseconds. In this video, you can see that we used the timer tool to assess laryngeal vestibule closure duration. Using frame-by-frame analysis, proceed to the first frame of laryngeal vestibule closure, turn on the timer, advance frame by frame to the first frame of laryngeal vestibule reopening, and laryngeal vestibule closure duration is typically measured in milliseconds. So using the timer in TIMS, the duration will then populate in seconds, and to convert this to milliseconds, we will multiply by 1,000. And so in this video example, the video demonstrates a duration of 0.4 seconds. Converted to milliseconds would be 400 milliseconds. Next, we'll talk about time to most complete laryngeal vestibule closure. This measures how quickly the laryngeal vestibule closes once the swallow is initiated. Time to most complete LVC is measured by calculating the time between the first frame of the hyoid burst and the first frame of laryngeal vestibule closure. This is also typically measured in milliseconds. And you can see how time to most complete LVC is calculated in TIMS. Using frame-by-frame analysis, we find the initial point of the hyoid burst, turn on the timer as shown by the red box, scrub frame by frame until the point of most complete laryngeal vestibule closure as shown on the right image. This is the time to most complete LVC in seconds. We can convert the duration to milliseconds by multiplying our duration of 0.266 by 1,000 to give us 266 milliseconds. Next up, we will talk about percentage-based ratio measures. On this slide, we will review how to obtain residue as a percent of the bolus. Using the freehand tool, magic wand, or magic brush, you will outline the entire bolus prior to UES opening. Then set the measurement to 100%. You can click the hide annotation using the eye icon. Then scrub forward frame by frame to the point at which the bolus has passed into the esophagus and the UES has closed. Then outline the material you wish to measure. TIMS will automatically determine the percentage compared to the original bolus. This video demonstrates how the measurement tools can be utilized to analyze residue as a percent of the bolus. That way, the way in which the tools are implemented are then determined by the discretion of the user. And so in this video, you can see that we're opening up our annotation toolbar, making sure we're on the thin line. And as mentioned, you can use the freehand, the magic wand, or magic brush to outline the original bolus. In this example, we're using the magic wand, outlining our original bolus, opening the measurement tool with the ruler icon, providing a label, and then changing the pixel measurement to 100%, hiding our original tracing, scrubbing forward after the patient swallows, and then here we're just highlighting our residue. And you have the option if you want to scrub backwards like we're doing here to where the residue is in a more cohesive area, and then using any of the three tools to now trace the residue. You can again add a label if you'd like, and then take a snapshot so that way you can put this measurement into your report or send it to PACS or your VNA along with your video imagery. We will now discuss anatomically normalized residue ratio measures. First, let's discuss the use of the C2 to 4 scaler. By using C2 to 4, we can obtain anatomically normalized measures and control for differences in pharyngeal size due to factors such as height and sex. When utilizing the aspect C method, total pharyngeal residue, or TPR, is completed. TPR is measured after the initial swallow of the bolus. It measures residue as a percentage of the C2 to 4 squared space. To complete the measure within TIMS, set your C2 to 4 scaler and set the line to 10 within the measurement tool. This action allows us to create a 10 by 10 box representative of the C2 to 4 squared space. Any subsequent measures will then be scaled to our C2 to 4 scaler as a percentage of 100. Next, you will measure the pharyngeal residue with the tool of your choice. So again, freehand, magic wand, or magic brush. TIMS will automatically determine the percentage of residue because of the work you completed with the scaler. The amount you obtain can then be compared to normative data. It is important to note that if you have multiple areas of residue, as we often see in those with dysphagia, you will need to trace multiple areas. TIMS will add up the tools using the new summation of tracing feature, which we'll show towards the end of the presentation. And here is a snapshot demonstrating how TPR can be calculated in TIMS MVP. Now we will discuss the laryngeal vestibule integrity. Although the primary focus of this presentation is quantitative measurement, certain physiological events may also be documented using dichotomous variables. These allow us to assess whether certain events are present or absent, complete or incomplete. Binary physiological markers may improve standardization and reliability when defining whether a swallowing event was achieved. Laryngeal vestibule integrity is a data point collected with the aspect C and aspect methods. Frame-by-frame analysis of laryngeal vestibule closure can be completed in TIMS. Incomplete laryngeal vestibule closure can be outlined using the freehand tool as shown in the picture on this slide. Now we will transition to discussing peak hyoid position. Peak hyoid position can be assessed using the C2 to 4 scaler or using a known object such as a penny. To assess using the C2 to 4 scaler, first scrub frame by frame to the point of peak hyoid position. Next, set your scaler using the line tool. After the scaler has been set, draw a line from the bottom front corner of C4 to the bottom front corner of the hyoid when it's at its peak position. Then divide the hyoid position by the C2 to 4 scaler. So in the example shown on the screen, the hyoid position is 235 pixels, and the C2 to 4 scaler is 158 pixels. Therefore, our calculation would be 235 pixels divided by 158 pixels, which equals 1.49. This means that the peak hyoid position is 1.4 times the length of C2 to 4. Our next topic is area-based normalized index using an anatomical scaler. Maximum pharyngeal constriction is completed in both aspect and aspect C. When completing maximum pharyngeal constriction, we will set the C2 to 4 scaler and set the length to 10 in the measurement tool. Next, we will measure the pharyngeal area at max pharyngeal constriction. In the event of multiple areas of tracing, TIMS will automatically add each tracing for one total sum. In the example captured in yellow, the sum is equivalent to 11.71%. Additionally, I want to note that the example with yellow tracing was provided during a TIMS University presentation with Dr. Steele and Emily Barrett. This webinar is complimentary on our website and is an awesome resource if you are interested in learning more about measurements from Aspect C after this webinar. Now we will discuss anatomical findings using pixel-based measurements. TIMS can be used for linear measurements. When a line or lines are drawn, the default unit of measurement is pixels. In a recent publication, Greger and colleagues used the line tool within TIMS MVP to assess anatomical findings for those with internal lymphedema secondary to head and neck cancer after one session of advanced pneumatic compression, as shown in these images. Similarly, the line tool can be used to assess internal anatomical findings for other patient populations, such as posterior pharyngeal wall edema post-ACDF. Next measurement we will discuss is maximum width of UES opening using pixel-based measurements. Using the line tool, we can measure the maximum width of UES opening as shown here. To obtain this data, we will review frame by frame to the point of maximum UES opening. Using the line tool, measure the width. Without a scaler, the data will be provided in pixels. And with that, I will pass it over to Brooke.
Awesome. Thanks, Shannon. So we'll now move on to our next discussion, which is how to complete quantitative measurements when completing FEES analysis using TIMS MVP. TIMS MVP provides the opportunity to complete numerous quantitative analysis for FEES, including the number of swallows per bolus, whiteout occurrence, time to whiteout duration, and the analysis of physiologic events. Automatic swallow detection is a tool that can be turned on within the TIMS MVP software, as shown here on the slide, which can help to improve analysis time and provide objective data. As you can see, when the tool is turned on, gray lines will appear in your FEES recording along the timeline. So I'll have you take a look here at this timeline. You can see these small gray indicators along the timeline. So these indicators are triggered in the software when whiteout occurs. In my own clinical practice, I typically record the entire FEES study rather than starting and stopping for individual clips, such as for each trial or strategy. So this tool comes in really helpful in terms of reviewing and analyzing. The automatic detection of whiteout in TIMS MVP was designed to help expedite that analysis process that I just mentioned, and I've seen that in my own practice after the study has been performed. We do know from recent publications that whiteout does not always occur even in healthy adults. However, this tool we still believe can be utilized to provide further objective data and increase efficiency in review. Okay, so we'll go ahead and turn on this video here. Time to whiteout can be calculated by starting the timer at the first frame after the endoscopist makes a statement regarding bolus presentation and timing until the first frame of complete whiteout. For example, when the bolus is at the lips, the person feeding the patient or the endoscopist can state thin liquid bolus presented now. When you're analyzing then, you would review frame by frame to determine the first frame after that statement is made. As Megan said, TIMS syncs video and audio, so you'll be able to find that first frame after the statement. And then you would turn on your timer tool and drag until the first frame of complete whiteout. So I'll go ahead and press play on that video again. So as you can see in this video, we can see how you can use frame by frame review and then the stopwatch tool that we've been talking about this evening to assess time to whiteout, which is described by Sutton and colleagues in their publication from 2024, which I just referenced a minute ago in regards to whiteout occurrence. So like I mentioned, you will just use your timer tool. So you can see some dragging there along the timeline. There's a white indicator, and that is indicating the duration of the event. And the time populates there as Shannon was discussing in seconds, and then we would convert that to milliseconds by multiplying by 1,000. You can also see the frame number adjacent to the event duration. Duration of whiteout can also be calculated using that same timer tool. So to complete this measure, again, you'll use that frame by frame analysis to advance to the first frame of complete whiteout, and you'll turn on the timer tool. And then you're going to drag something here on the timeline, and you can see as I'm dragging, or as I dragged along the timeline, there's that white indication. And so you would drag the cursor along the timeline to the first frame that the hypopharynx is visualized to measure the duration of the event. And again, the time will populate next to the timer tool in seconds. We would then convert that information to milliseconds by multiplying by 1000. So with that, I will hand over the floor to Megan as she discusses our next topic.
Great, thanks, Brooke. Next, we are going to review the scorecards that are currently available in the TIMS MVP 6.1 software. So as you can see in this snapshot, scorecards can be accessed via that top toolbar by clicking on the score icon. By clicking the drop-down arrow on the scorecard menu, you can visualize all of the scorecards within the software. And you will note that there are analysis tools for both MBSS and for FEES. In this demonstration video, you can see how easy it is to access the scorecards and complete them. I can then copy and paste the information directly into my EMR, or I can use the TIMS customized report, which automatically pulls the data forward for me. And so you can see here, as you're reviewing your trials, you're able to go in and start filling out those scorecards. And then, as I mentioned, you'll be able to use that function in the top right-hand corner to copy that and paste it into your EMR, or if you're going to use the TIMS reporting features, it will pull forward for you. And as you can see in this video, the safety, efficiency, and digest grade are automatically calculated on the results tab. You can easily copy and paste the scorecard into your EMR using that copy button that I just mentioned. And then the scores can also be auto-populated into that custom report. This video demonstrates how TIMS can be used to complete the MBSI&P scorecard and upload the data into that global swallowing database that Brooke mentioned earlier. So you can do this all directly from within the TIMS software. There is no need to open up a separate browser. Okay. Next, we will discuss the notes feature within the TIMS MVP software. So another tool that helps support efficiency and analysis is the notes tool. As shown in this video, notes can be pulled up during your MBSS or FEES analysis and travels with you from clip to clip. As you can see, users can utilize preset note templates with drop-downs and free text abilities. They can create custom note templates, or they can utilize free text throughout the analysis process. Further, notes can be helpful to track quantitative data throughout your analysis. So it's almost kind of like a post-it note within your study. If you're just using it to track that quantitative data, it will be saved there for you to reference. And then on this slide, you can see a snapshot of the robust esophageal screening test, or REST, which can be found in that notes tool. Next up, we'll talk about the customized reporting feature. So this video demonstrates the TIMS semi-automated reporting feature. As you're completing your analysis, TIMS is working in the background to pull everything forward into a customized report. This includes your snapshots, notes, and those scorecards. This feature does not have to be utilized by teams, but it can be a powerful time-saving option. Additionally, if you have templates within your EMR that you prefer, you can easily copy and paste scorecards and snapshots into your pre-existing EMR template. And here we're showing you that highlighted, that's that notes section pulling forward. You can see those snapshots and then the template information. Right. And with that, I will go ahead and pass it over to Brooke.
Awesome. So we are now going to discuss additional tools within TIMS MVP, some of which are brand new. All right, go ahead and press play here. A new tool in TIMS MVP 6.1, Film Strip, allows users to review studies frame by frame in a dynamic 3x3 grid, as you can see here in this video. Film Strip lets you see the exact moments immediately before and after your selected image, which makes it easier to assess swallowing and vocal fold events. You can adjust the offset to show images 1 to 4 frames away, and you can also zoom in or out to get your preferred view. You can also capture film strip snapshots and add them directly into your report, like Megan just demonstrated, which just helps with clear education and documentation. And any of our snapshots, if you prefer to use templates within your EMR, you can actually copy those right into your EMR, which is pretty great. And I do want to mention that the film strip tool was originally developed for video stroboscopy, but many clinicians and users have already found it to be highly beneficial for both FEES and MBS. Film strip shows bolus progression across that 3x3 grid and allows users to see 9 frames at once instead of a single frame while still navigating frame by frame, and you can also move forwards or backwards, which is pretty cool. All right, so in this video, you can see a new feature within TIMS MVP, which Shannon mentioned earlier, summation of measures. So with the launch of TIMS MVP 6.1, the software now automatically adds multiple areas of tracing for one final sum. So this feature was developed due to direct feedback from Dr. Steele's lab. We want to highlight that many of the features and tools within the TIMS MVP software were developed based from direct feedback from clinicians and researchers. So we want to throw that out there because if you're using our software for research or clinical practice or teaching, and there's something that you would like to see made better or added to the software, please reach out and let us know because our engineering team is really incredible and does take that feedback into consideration. So here in this video, you can see that there are multiple areas of residue here. We are extending that area of tolerance, and you can see now that there are 2 areas of tracing that TIMS has added up, which is a percentage of that original bolus that we set to 100%. And now we've got our notes open, like Megan just demonstrated, and we're able to track that quantitative data right there in the notes, and then that information can either be pulled forward into your customized report, or you can just copy it and paste it right into your EMR. So before moving on to the next slide, I do just want to extend our thanks to Dr. Steele's lab for their ongoing collaboration with both our clinical and engineering teams because their feedback and collaboration really helped us not only with this presentation, but also with advancements in the software. So we are extremely grateful. All right, I'm going to go ahead and press play. So in this video, you can see how our compare feature can be used to analyze within the same study. So this can be used if you are wishing to compare differences in bolus trials or perhaps compensatory strategies. So you can play both videos side by side simultaneously. You can take a snapshot using that little camera icon there. You can also compare between studies, as you can see I'm demonstrating there at the top. So we'll go to our next slide so you can see that and a better view here. All right, so in this screenshot, you can see how compare can be used to assess a patient's swallow when they have completed both a FEES and an MBS. So, if you're seeing a patient for both studies, or maybe you're seeing them for multiple MBS or multiple FEES, you can use the compare feature to analyze progress over time, which is pretty cool. So, like I mentioned, the feature allows us as clinicians or researchers to review previous studies for the same patient side by side and frame by frame. You can compare 2 different modalities, as I mentioned, or the same modality. So, for example, if patient Paul Smith completed 2 MBS in January and then a FEES in February, I could use compare to assess his 2 MBS side by side. I could compare his MBS to his FEES from February, or I could compare within the same study. You can also, like I mentioned, take those side-by-side comparison snapshots utilizing that camera icon in the center. So like in this example here on the screen, it's, I think, nice for for various purposes to have pictures of the anatomical structures we're looking at from both the standpoint of video fluoroscopy and FEES. So in this case, for someone with head and neck cancer. So you can do that right there within the compare feature, and then you can include that in your customized TIMS report, excuse me, like Megan mentioned, or if you want to continue using your reports within your EMR, you can easily just copy and paste right into your preferred template. All right, I'll go ahead and press play here on our patient view video. So another tool that is available within TIMS MVP that has been out for a while, but maybe you're not as aware of it yet. I think it's pretty cool. It's our patient view tool, which is applicable for both MBS and FEES, and is available to TIMS MVP users. So in this video, you can see that I am scoping myself and using patient view to capture both internal and external footage at the same time. So this can be a highly beneficial tool for biofeedback for the patient. An example that I think would be really cool to apply this tool as a biofeedback tool would be for people with head and neck cancer that are undergoing manual lymphatic drainage, because we can give patients those recordings and help them. Well, they could see it in real time, but then they could also have the recording to see how different manual techniques help improve internal lymphatic function. And then patient view can also, of course, be utilized within the fluoro suite. So you can see in the screenshot there on the left how that could be done. And an example in that case could be to use the tool to assess a patient's response to events such as aspiration. So if anyone attending this webinar live or watching on demand is certified in MBTP, it'd be pretty cool to use patient view as an adjunct to your video fluoroscopy assessments if you are using the MDTP program. Okay, so our next tool we're going to talk about is TIMS Connect, which is a tool that is included for 1 year with every TIMS MVP license. Connect enables secure remote access for collaboration, consultation, and education. So we currently have researchers, clinicians, and healthcare teams that are already using TIMS Connect to overcome a variety of issues such as pediatric radiology shortages, to enhance coordination among surgical and diagnostic teams, to expand televideo fluoroscopy between international students, to support graduate level training, to promote standardization among team members for MBS performance, and to provide remote FEES mentorship and support. So in this picture here on the screen, you can see how Dr. Georgia Malandraki used TIMS Connect to host what we believe is the first ever international video fluoroscopy collaborative teaching session. So you can see that there's a volunteer there in the middle of the C-arm, and they are performing a modified random swallow study there with TIMS. And they also, in addition to TIMS Connect, use Zoom so that even more people could log on, which is pretty cool. And this was a collaborative learning opportunity so that people, students, could, learn as if they were right there in the fluoro suite, even though they were joining the session from all over the world. So pretty cool. And like I mentioned, there are a lot of healthcare teams that are actually using TIMS Connect to help address issues that we see all the time in clinical practice, like shortages with radiology and with standardization projects to help everyone get on the same page in terms of the performance of modified barium swallow studies as well as our FEES examinations. So we know that we covered a ton of information so far during this webinar, and we want to make sure that you all feel supported and have access to resources. So if you want to access step-by-step instructions for any of the quantitative measures that we discussed and reviewed this evening, you can scan this QR code above. This will also be included in the emails from Zoom. And I haven't had a chance to look at the chat yet, but I'm sure Shannon or Megan put it in the chat as well. But this webpage details every measure that we talked about this evening. In addition, there are links for further information about, just additional training opportunities and things like that. I will note that the page does not cover every single measure that can be completed, but we were really just striving to create a resource that was accessible to people and that the information regarding how to complete the measures were also accessible. So, if there's something else you'd like to see, please reach out and let us know. And we're happy to, work with teams in terms of like updating that page. And again, we do want to shout out Dr. Steele's lab for helping us in reviewing that content. So that will go to our last slide, which is just Q&A. We want to thank you for joining us this evening. We left a ton of time just for the floor to be open for questions. We're happy to open the TIM software and demonstrate any of this live. I'll fast forward here to our references in case you want to check those out, and then I'll stop sharing and jump into the webinar here so I can see what's going on in the chat. But if you all have questions, feel free to put them in the chat and I will check out what's going on here to see if there's anything we can help answer. Okay, so great question. Heidi said, how does this help with radiologist shortages? That's an awesome question. So I'll give you an example. Children's Hospital in St. Louis, they are having really hard time finding pediatric radiologists. So they're actually using TIMS Connect to have pediatric radiologists from other parts of the country remote in live to the session. So I don't know if you could tell on that slide that I shared, but it's kind of like joining a Zoom call. The radiologist can see what's going on in the floor suite and they can actually communicate in real time to the clinician and they can communicate to the patient. So it's pretty cool. I had the opportunity to go and shadow the speech pathology team there a while back, and it's just been super helpful for their program because they're having a hard time, just with access to pediatric radiologists. So other examples, we've had healthcare systems that are using TIMS Connect to support leak testing for patients with head and neck cancer. So if they're wanting to do a leak test and the surgeons, don't have time to run all the way from the OR back to radiology, some of those teams are using TIMS Connect to jump in virtually to the fluoro suite via TIMS Connect. And then, other teams are using it to help with standardization of MBS and FEES performance. Okay. Yes. So then Katie said, I might have missed this. Can the templates within TIMS be modified? I'll stop talking and let Shannon and Megan take that one because they're experts in that.
Yeah, so Katie, that's a good question. The TIMS templates can be modified. We actually offer a course weekly that reviews how to customize your report templates, and that course goes over customizing those report templates as well as those note templates, and then also adding in quick phrases into your software, which if you're an Epic user, those are similar to smart phrases where you can kind of drop a template into your template on a patient-by-patient, case-by-case basis, just to help with efficiency and help save time. But these templates are all fully customizable. And again, we offer that course and we'd be happy to send you more information on that. And I'll also drop the link in here just to our TIMS learning platform that has all of our courses on it. If those times don't work, feel free to email us at training@tims.com and we'll get you set up with someone.
And I also wanted to kind of add on, because I know Maggie had a similar question about her Meditech version being compatible with the TIMS reports. So as long as the Meditech can accept and upload, I think sometimes copy and paste can be difficult with some EMRs with like pictures or tables. So another option could be if you can just upload, you can save the TIMS report as a PDF if the copy and paste is not accessible. The other option that I've seen some sites do is they will print the report and then scan it into their EMR if the uploading is also not an option. And then finally, some sites will also set it up so they can send it as a PDF attachment to PACS or their VNA with the video imagery. So there's several different ways of getting the TIMS report into your EMR. Just depends on your EMR type. And again, like Megan mentioned, we have training and can talk with you, individually more to kind of figure out what is the best plan for your EMR.
I know Elizabeth asked about the norms for the different measures and parameters. That's a great question. So currently the software does not include those norms in like any sort of like scorecard or anything, but you can easily save it in your own software. We did include on that quantitative analysis page on the website links to the publication. So, for example, Dr. Steele's lab has provided a lot of normative data, which is really, phenomenal and a game changer for us as practicing clinicians and for research as well. I'm just speaking for myself because I practice. But you can actually copy the table if you want or information, however you'd like to do so, and save it as a notes template. So if you, and we can pull up the software here in a bit and show you how that can be done. But in the video demonstrations that we showed, those notes templates that are popping up are automatically saved in my TIMS system. So in my own clinical practice, my team prefers to use the templates within Epic. We use the flow sheets and things like that. But when I'm doing my analysis for MBS or FEES, I'm always using or leveraging that TIMS review workflow that Megan showed at the beginning so that I can take more time to perform some of these quantitative analysis and take snapshots and all that jazz. And then I can use that little sticky note that we showed, and I could use the templates in there. I could save the normative data as a template to reference while I'm going through each of the clips and then performing my measurements, and then easily just copy and paste that information into Epic. So like I mentioned, that's what I do in my own practice. If I'm doing any kind of like measurements or scorecards or using the sticky notes tool like I was just doing yesterday, I was typing my analysis in the sticky note in TIMS because it travels with you as you're going series by series, and then I just copied that information and popped it right into Epic. So again, speaking from experience, I remember the days of having to like hand write everything down when I was at my TIMS cart in radiology, and then retyping it into Meditech. So we've come light years from that, which is awesome. And then I know there's been several questions about TIMS Connect for radiology shortages. Another example would be like if your radiologist isn't wanting to come into the fluoro suite, but they still want to have that collaborative opportunity. You could use TIMS Connect for that as well. In terms of like a database or pool of radiologists that can be accessed via TIMS Connect, I know that there are different like regulations for different states as well as different sites as far as, like remote collaboration. So you definitely want to like look into that. But in terms of like a database or pool, we don't provide that as TIMS. We just provide the tool to help make that connection happen. That being said, if you do have questions about TIMS Connect or like how some of the sites that we work with have used it and like found radiologists to remote in, I would be happy to connect you to speech pathologists that help direct some of those programs. So we can just pop our email for training in the chat. So if you have more questions about TIMS Connect and you want to like jump on a call to kind of problem solve your exact team situation, we'd be happy to do that as well. Let's see here. Oh yes, okay, cool. Someone put in the chat about how you can paste into MedTech, which is great. And great, okay. Did I miss anything else? Let's see. I think I might have got it all. Let's see. Oh, okay. Yeah. So somebody asked about the other websites that keep getting mentioned. That quantitative page that I shared, which we can share again in the chat, does have links out to all of the analysis methods, which, like I said, a lot of all of the quantitative measures that we discussed this evening are open access to learn how to perform them. And we talked about TIMS this evening, obviously, because we work at TIMS, and we do know that thousands of speech pathologists here in the United States, Canada, and Europe, as well as countries elsewhere, have access to TIMS. So it's pretty accessible. But even if you don't have TIMS, you can perform a lot of these measures in other currently available software, a free one of which being ImageJ. But like I said, since so many people do have TIMS and it's really easy, we mainly focused on that this evening. But that being said, that quantitative page does have a ton of links out to like where we got the information, how you can learn more. And then at the beginning of the presentation, we talked about analysis methods for MBS and FEES, specifically MBS IMP, digest, um, the rest, aspect C, and then vases. And some of those are free to learn how to do, and then others do require that you take like a training program. So we do have free webinars for each of those analysis methods on our website on our on-demand page. So I can actually pull that up here just so people can see where you would access that. But we would, encourage you to check out those sites yourself, like the training sites and stuff, because we have each completed the trainings for those analysis methods, and they are, in our opinion, really beneficial. So when you come to like Tim's website here, and then you would go to our Tim's University, and then on demand, and then you can see that all of the links are there. So you would go to FEES, MBS, and high resolution frontal anemometry, and then this is going to pop you down. My internet must be going a little bit slow here, but this will pop you down to a section talking about a lot of these different methods that we reviewed this evening. I'll go ahead and stop sharing there. Let's see. Did I miss anything else in the chat? Great.
And
Does
there
anybody
was
have
a question, Brooke, in the Q&A if you haven't opened that too.
Let's see. Okay, so I'm gonna read it out loud so that everyone can hear what the question is. So, although important, especially across time for the same patient, the measurement of prevertebral swelling might be considered by radiologists, neurosurgeons, and ENTs as being outside of the scope of an MBS, which should be more narrowly focused on swallow physiology. Do you get this kind of pushback? Yeah, so that's a great question, Craig. We're definitely not like telling you absolutely have to do any of these analysis methods or obtain any of the data that we presented this evening. We just provided that information, the information as examples. So, personally in my own clinical practice, internal lymphedema is something that I have looked at a lot over the past 10 years. And the line tool that Shannon discussed, and she, provided the images from Jessica Greger's team at Mayo Clinic demonstrating that was just really helpful and providing information about the reduction of internal lymphatic changes using advanced pneumatic compression. So that was obviously for research purposes, but I have also actually utilized that information with, blessing and collaboration from the interdisciplinary team to help with fighting for coverage for tools to help support that patient population. So I think, the example of, swelling post ACDF, you would just maybe talk with your team about whether or not that was data that they wanted using that line tool. So I can give you another example. I had recently seen a patient that had an ACDF and was having severe swallowing issues. And so she was referred for a swallow study, and specifically they were curious to know whether or not the hardware should be removed. So, in that case, if the surgeon is reaching out to you and asking for your clinical expertise, I think it's totally reasonable to ask if they would want data regarding that. But of course, you always want to make sure that you're staying within your scope of practice and that you are collaborating with an interdisciplinary team and not talking about things that, that we shouldn't be talking about. So, yeah, awesome. Thanks, Craig. Yeah, the other thing too, we did briefly talk about max, or excuse me, we talked about UES max width, which again, in my opinion, you would want to set that scalar, like Jessica did in her internal lymphedema study. So like if you are, recommending that the patient go for follow-up with, potential consideration of some sort of intervention to address UES opening, you could set that C2 to 4 scalar, like Jessica did in her publication, then measure the max opening of the UES, and then, you refer the patient, and the patient gets, let's say, maybe a dilation, and they come back in for a swallow study. You could use TIMS then get that scout image, make sure they're in relatively the same position. And you could easily do that using that line tool in TIMS. Okay, we're good to go. And then, you administer your same trial and then use the line tool again, and you could see, you can prove then whether or not that dilation was effective. So again, I'm presenting this information coming from a lot of experience with that head and neck cancer population who often really struggle to get different treatment modalities approved through insurance, which is just crazy. But the more objective data that we can provide as clinicians and, making sure, like we said, staying within that scope of practice and collaborating with the team, I think is just really valuable. Okay, yeah, great question, Erin. So she said, do y'all have resources that can be shared with radiologists about the importance of 30 frames per second in MBS? I've always gotten major pushback on this despite providing evidence. Yes, we do have actually a pre-made document. Happy to send it to you, Erin, if you want to like just message the panelists, or we can send our training email in the chat if you'd like to reach out to us, whatever works. We can send you that document. And we do actually have some screenshots too showing that I don't know what you're recording at, but like if you're recording at 15, then you know you're just getting duplicates. And you're missing information. So there's a ton of research out there to discuss the importance of 30 frames per second or continuous fluoro. So happy to provide that to you. Let's see. I think we got them all so far. Is there anything you guys would like to see in the software? Let us know in the chat or the Q&A. Otherwise, I can go ahead and just at least pull it up so you can see it. We still have some time here. Let's see.
Brooke, did you see Daniel's question about which features are most practical for clinical practice?
Oh, sweet. No, I did not. Thanks for the question, Daniel. So like I mentioned, I do still practice clinically, and I am extremely grateful. My team does have access to Tim's MVP for fees and MBS, and that was not my doing. That was my awesome supervisor, Claire, that worked really hard to get those tools implemented, as well as that Tim's review workflow that I mentioned, which is super helpful because then you can actually use these tools. So I know, we covered that in this presentation because we know that not everybody has the Tim's review workflow set up. So if you don't, highly recommend reaching out to us. That comes free with your Tim's. So set it up so you can use these tools. But Daniel, in my own practice, as you know, it's busy. You get busy. So it can be hard to implement all of the things we talked about tonight. So what I recommend to people who are just starting out with, quantitative analysis or, looking to standardize their NBS or fees analysis within the team is just to start with the foundation. So for example, if not everyone's on the same page with what they're using to analyze and rate MBS and fees, start there in your TIM software using the scorecards. That's super easy. It takes seconds to do, and we can demo it here. And then you can copy and paste that information right into your EMR. I do it every time I'm at work and I'm doing, an MBS or a fees. It's super easy. But then from there, personally, I often use the freehand tool, Magic Wand or Magic Brush, to assess residue and aspiration as an estimate of the original bolus. I personally found that to be extremely helpful over the past 4 or 5 years now since that feature has been out. I think Shannon demonstrated that. It's pretty fast to do. And now with the new 6.1 software, I got to use it in real life. I've obviously been using it on my Tim's computer, but in clinical practice, I got to use it in real life this week, which was so fun just because it adds it adds the tracings up for you now, which is great. Makes things a little bit faster. So I personally found that helpful. And I'll give you an example. I had a patient, this is a few years back, that I saw in the ER. I was like, okay, I think this person is having swallowing issues. Let's go for a video. Took the patient for a video. The patient did have an episode of aspiration, but I still recommended a regular diet, thin liquids. And the nurse called me. She's like, why did you, recommend a regular diet for this patient? I saw that you said he aspirated. But then we were able to like talk through the measurements that I did. I don't remember the exact percentage, but it was like something so small, like 1% or something. So I think it's just really helpful to provide that objective data for our interdisciplinary colleagues. It just provides more rationale for why we're making the recommendations we're recommending. And then you can include those snapshots in your report. So I'm actually going to share screen just so people can see what I'm talking about with this. So I'll open my Tim's here and the Zoom thing. So this was a real study that I did. And I do have consent to share this. So for example, this patient had um, this is actually an improvement across studies, but you can see that the patient consistently had about 64% residue after the swallow. And I was able to determine that with that freehand tool here. So I'm able to, put that information in my report. Telestrations are another thing. So just, putting pictures into your report about what you were identifying during the study and how you were providing objective data. So here you can see this is 2.5% of that original bolus that was aspirated, and that side-by-side comparison there. So, I know that my clinical team has actually gotten feedback from other teams and physicians in the area saying that they love our fees and MBS reports because we do have those photos in there. We add in illustrations to point out what we're talking about. And then we're using those measurements. So I would say if you're wanting to do something super fast, learn something super fast, to apply tomorrow in your clinical practice, check out the scorecards. And I'll share again so you can see where to access those. If you forgot, it's just this little score tab up here. So you can see for this patient, I did MBS, IMP, and then digest. And then, like Megan said, this is locked because I already did it, but you just copy it and you can paste it right into your EMR. So you can do that. You could take some snapshots there. You could add in illustrations and then use that freehand tool to do some measurements. So that's what I would do. That's what I did do when I first got into looking at increasing objective information as objective as we can get with MBS and fees about 4 or 5 years ago. I started with that bolus estimate, and then the scorecards in TIMS, and then from there you can move on and look at. I think the next thing that's pretty easy are the timing measures. So we demonstrate a lot of timing measures that you can do in TIMS. So like duration of LVC, you can do a lot of mainly timing measures and fees as well. And then Shannon talked about the LVC integrity, which is another one. Super easy, takes seconds to identify whether or not that's present. And then you could use our freehand tool just to outline it. Like this patient had consistent incomplete LVC. Here's a picture, and here's what happened as a result. Okay, let's see here. Oh, sure. Yeah, Megan said she'd like to see a demo of the scorecard. So I'll open a new study so we can do that quick. And then, yeah, so Molly asked, have any of you used the time to white out and or duration of whiteout information in a clinical way that you can share? Yeah, that's a really great question, Molly. So I kind of talked about this a little bit when I was presenting the information. The primary way in which that I'm using the automatic swallow detection, which is it's triggered based on whiteout. So, for example, if a person's achieving 90% of the pixels on the screen as white, then the TIM software is identifying that as whiteout has occurred, and it'll create those little markers on the timeline there. So, in my own practice, like one of the biggest benefits I have personally seen of that tool is the fact that it just speeds up that analysis time because I don't know about you all, but I have a problem with talking too much. So sometimes I'll hit record and then I sit there and talk to the patient for a second and then, you know, uh, a coworker or a colleague of mine, Hillary Cooper, mentioned the benefits of like taking a look in the mouth before you actually pass the scope, just so you've got a nice picture of oral health before you pass the scope and then passing the scope. So there could be some information in my recording before the person ever has like any pre-swallow tasks or any actual trials. So that tool has been really helpful for me in analysis because, first of all, I can count how many times they actually achieved whiteout, and then I can scrub forward using frame by frame to that very first time that they, achieved whiteout, and then I know about where I'm at in the study. So I think other ways that this can be utilized clinically. One, like I said, in that publication from Sutton and colleagues from 2024, I don't know if y'all have read it, but it's great. It's has a lot of normative data in it about swallowing as identified via fees. So super important, and I know that that group is working on another publication, which is great. And I know some of them do have access to Tim's MVP and maybe utilizing that in some of their research. So we'll be excited to see what they find. But from that publication, we know that even in healthy adults, we don't always achieve whiteout. So I think one of the ways in which you could use the automatic swallow detection, which is looking at whiteout, would be to see if if a patient consistently does not achieve whiteout, and it's more often that they're not achieving it versus they are achieving it. Obviously, that's an indicator that something is wrong, physiologically speaking. And so you could actually compare that data. Like, let's say you see them for their baseline study, and then you do, I don't know, 5 sessions of dysphagia treatment if you're at acute care and you get that much time. Or maybe you're an outpatient and you get 10 sessions or something. And then you do a follow-up fees and you have that tool turned on again, then you can see if the number of um, times that they achieve whiteout increases. So I think counting those, and then you could also look at duration. So you can measure, the duration. Are they able to sustain that whiteout in order to achieve airway protection? So um, let's see. Daniel said, any potential interference with surgical clips or hardware? Daniel, I'm assuming you're meaning with measurements. And yes, that can definitely happen. That's where that frame by frame review is so important. That this actually legitimately happened to me yesterday. And so my colleague and I in radiology were looking at a study, and anyways, we did have to use frame by frame review to make sure that what we were looking at was bolus related and not something else. So, um, okay, great. Okay, cool. Let's go ahead and open up the TIM software so that we can take a look again at those scorecards because I know that we want to see those. So like I mentioned, you'll just click on score at the top. And then for this patient, you can see the different scorecards here. And I'm going to go to a new study just so we can take a look at what it would look like if you were, let's say you just sent this up from radiology to your TIMS review in your office. You could, you could see your series here on the side. And then we get to open up our scorecards. So you'll click on score. You can see that this one already does have a couple of scorecards completed. So let's go ahead and start over here. So if you're starting from the beginning, you'll click on score. You'll click the drop down here. And like Megan demonstrated, there are scorecards in here for fees and MBS. We actually do have more scorecards than this made, and they are all available open access on our website to download and import into your TIM. So if you need help with that, let us know. But these are the scorecards that are currently shipping with the software. So let's say that we wanted to score digest. We'll click on digest. And again, if you've done the digest training, which I highly recommend, it's really great. Then you'll be familiar with the like the tree, but that was integrated into the software with Dr. Hutchison. So anything that you're seeing in the TIM software in terms of scorecards, we did work with the researchers to implement that. So just know that we didn't just make this up and like plop it into the software. We did work with the team. So when you can either type in the rating here or use the up and down arrows, or if you click the little drop down here, it's going to remind you about the various scores. So I can sit here and, just fill out my scores, and you can see that as I'm doing so, there's a visual analog scale there at the top. And the colors just correspond to how I'm, performing these ratings. And then, like Megan said, if you click the results tab there, you're going to get your overall safety, efficiency, um, safety grade, efficiency grade, and digest score. And then you could copy that right into your EMR. And then, like we talked about, if you want to use a Tim's customized report, you can. And those can, populate forward into your, let's refresh this here, into your report. So, and I will say I have Epic at my hospital, and the scorecards do look like this. If you just click copy here and then paste it right in Epic, they look the same as that. And then same thing with, we'll open this back up. Like our photos here that we have, they look just like this in Epic, which is nice. So like if there's something that you're wanting to point out, you can say, you can type right under it in Epic, or you can say like, reference photo above. So pretty cool. Let's see here. Okay. Did we get all of okay. Yeah, question about video stroboscopy. Yeah, so if anyone is performing video stroboscopy and interested in using that film strip tool that we talked about, which is here on the right-hand side of the screen, and you have questions about it, or you'd like to trial it, please reach out to us and let us know. That's why that tool was originally designed, was to help our colleagues that are performing video stroboscopy. Similar to FEES, we're aware that people that are performing video stroboscopy might have issues with archiving their studies. So, we didn't talk a lot about archiving this evening, but an important thing for all of us to consider as speech pathologists for MBS, FEES, or video stroboscopy is that we are archiving our studies, and not everyone is able to do that depending upon their software. So, you just want to make sure that you have some way of doing that. But, we can say that Tim's MVP was specifically designed to do that. And that's why it took our engineering team around 10 years to come out with that initial Tim's MVP for FEES. And now it's also applicable to video stroboscopy, colonoscopies, like any kind of endoscopy. Tim's can capture and archive and send to PACS or VNA, which is really a game changer because a lot of softwares out there do not allow you to do that, meaning that they do not integrate with PACS or VNA, and they don't integrate with your EMR. So, that can pose a lot of problems, issues with interdisciplinary collaboration, increase costs for the hospital if they're, every person on the team has to have a login and things like that. And then additionally, we also have unfortunately met with teams that have advocated really, really hard to get, for example, FEES equipment, and then they get the FEES equipment and then they're unable to archive those studies over to their PACS or VNA, and they're forced to delete studies. So that obviously is just not a good situation to be in, especially if your team or your hospital is audited and you can't provide those records. If you're billing that FEES code, you have to make sure that you have a recording of the study somewhere. So, if you're having any issues with that, reach out to us. We're happy to help navigate that. Like I said, there are different options on the market, but Tim's is a really easy thing to add to your clinical workflow that immediately solves that problem. So let's see. Cool. All right, yeah, I know there's some questions, and we're almost now at 9:30, so we can go through housekeeping stuff. Again, we want to thank you guys for joining us this evening. It's always great just to collaborate and learn together. If y'all have feedback about the presentation or anything that you're seeing in Tim's, please reach out to us because, like I said, we do take that feedback really seriously, and our engineers implement changes that are recommended into the software. But if you'd like Ashes to use for attending the presentation, just complete the survey that Shannon. Oh, Shannon, let's see. Will you post that to everyone? It looks like it just went to the hosts. Shannon will post the survey link there in the chat again, and then we will send it out via email as well. And then the replay should be up on the website no later than tomorrow. And then we'll also link the quantitative page if you want to check out more how to do measurements. I know there's some questions about that. So just, maybe do one at a time. And then again, make sure that you're just applying it in a way that's functional for you and answers your clinical question or research question. If you would like to jump on a call with us and talk more about any of this, any of these topics, we're happy to do that. And if you would like a certificate, just email us at tims-univ@tims.com. Awesome. Well, with that, we will go ahead and sign off. And again, thanks everybody for joining us, and we hope that you have a great rest of your evening. Bye, everybody.